Hello, good morning. My name is Isha Chitroda from MD3, and today I'm going to be presenting my FPS ORP1. So here's the case that we have. A 72-year-old man presents with fever, dizziness, and sweating. He also has shortness of breath after walking for 100 feet and gets exhausted very easily. So at night he's unable to sleep because of shortness of breath, and his feet have become swollen. And after taking some measurements, it was found that his blood pressure was 90/62. He had his heart rate was 96 beats per minute, and he had a respiratory rate of 16 breaths per minute. Also, there was inspiratory crackles that were heard on inspiration. Also, his neck and head revealed pink pimples without pallor. Also, he had some heart murmurs here and there, which we'll talk about also. The patient was given piperacillin tazobactam, and he was positive for the bacteria E. coli. So let's talk about different types of shocks and what shock is. So it's basically a life-threatening condition where blood is unable to perfuse along your body, and this can cause hypoxia and ischemia, and it can cause stomach failure, and this can be fatal. So let's talk about the different types of shock. So the first one we have is cardiogenic shock. In cardiogenic shock, it's basically where your heart is able to pump blood. The problem is with your heart itself. So this can be due to multiple different things. The first thing we have is cardiac tamponade. It's basically like fluid pushing against your heart, and you have myocardial infarction, basically necrosis of your tissue, your heart tissue, your myocardial and because of that, obviously, you won't be able to pump blood. Also, ventricular arrhythmias, any type of arrhythmias where there is a problem in the injection of blood into the systemic circulation. Then you also have obstructions. Obviously, if you're gonna have obstructions, then your blood will not be able to reach the organs that you want. And also, valve stenosis. That's a really big problem because it won't be able to go through the valves because they will harden. Second, we have hypovolemic shock. This is basically hypovolemic means decrease in the volume. And this can be due to two things, either just loss of blood or loss of any sort of fluid in your body. So mainly water loss can be due to vomiting, diarrhea, and things like that. And then we have loss of blood, which can be due to major hemorrhages and major blood loss because of your GI bleeds, aortic rupture. You may have ectopic pregnancy. Basically, we're talking about hemorrhage. So basically, this would basically have loss of fluid and loss of volume, which could lead in hypovolemia. So we're going to talk about neurogenic shock now. So neurogenic shock is mainly due to loss of sympathetic activity. This can be due to like a spinal injury anywhere in your spinal cord. And this what it does, it increases the vagal tone or the parasympathetic activity. And you would have vasodilation, of course, because there won't be able to sympathetic there's no sympathetic innervation on the blood vessels, so that will result in vasodilation. You also have decreased venous return and preload, which will lead to decrease in cardiac output, and then this would result in decrease of perfusion to the rest of the body, leading to shock, and obviously you would have bradycardia and hypotension. Now we're going to talk about anaphylactic shock. So anaphylactic shock is because of allergic reaction or any type of hypersensitivity reaction that the person could have to any allergens, and this is mostly mediated by histamine. So you can be allergic to food, drugs, insect bites, things like that. So you would have a variety of symptoms: rashes, bronchospasm, vasodilation. This can lead to inflammation too, and of course anaphylactic shock, and eventually you might even have respiratory distress. Now, the main one, which is septic shock, which is what this case is talking about. So this case is a solid case of a septic shock. So we're going to talk about how we know that this is septic shock and how the patient's symptoms relates to the symptom of how septic shock presents itself. So septic shock is basically abnormalities in organ system, and this can be due to microbial infection causing hypotension. So the symptoms, general symptoms would be tachycardia, hypotension, dizziness, shortness of breath, and tachycardial heart defects. So let's talk about how we can tell that this patient has a septic shock. So firstly, this patient does present with dizziness, shortness of breath, and he has hypotension. His blood pressure is 90/60. Then he has tachycardia. He has 96 beats per minute. Normally, the range is 60 to 100. I would say is more on the higher side. This person presents with pale pink skin. Also, tachycardial heart defects. Basically, any type of ventricular tachycardia, arrhythmias, and things like that. So yeah, that's how we can tell that this person presents with septic shock. Now the ECG findings. So basically this person has widening of the QRS complex, decrease of QRS amplitude, and bundle branch block. How we talked about earlier, the tachycardial arrhythmias that this person can have because of the septic shock, and it's the decrease in the QRS amplitude is basically because it alters alters the contractility and the excitability of the ventricles to pump blood. So we're going to talk about dilated and hypertrophic cardiomyopathy. So these are two different types of myopathies. So firstly, hypertrophic cardiomyopathy can be physiological and pathological. It is where you have thickening of the intraventricular septum, and it can be due to increased ventricular ejection, left ventricular ejection. This can be because you have if you are hypertensive, you have more venous return. That means like you have to there's more blood that the heart is pumping. So that means that the muscle is being used more, the heart muscle is being used more, which can result in hypertrophic cardiomyopathy. Can result in arrhythmias, fatigue, shortness of breath. Next, we have dilated cardiomyopathy. There's basically a dilation of the heart chambers. That was thickening of the septum, and here's dilation. So you'll have like the chambers will enlarge, and this causes systolic dysfunctions and decrease in ejection fraction. So it can be due to mural thrombosis, mitral valve regurgitation, dyspnea, fatigues, and peripheral edema. So we're going to talk about how we can manage hypertension. So like the major class of drugs that we can talk about here is alpha adrenoreceptor agonists. They're very important because that is the main one where you, when they act on the alpha-1 receptors, what they do is there is constriction of the muscles, so that increases the blood pressure. So drugs like methoxamine and phenylephrine that directly acts on alpha-1 receptors, vasoconstriction, and increase blood pressure. You also have norepinephrine and epinephrine, which acts on alpha-1 receptor, but epinephrine specifically in larger doses, because in lower doses they would affect beta-2 receptors more. So they also act on alpha-1 receptors. And then you have midodrine that also acts on alpha-1 receptor, and it can increase blood pressure. Now let's talk about endotoxin. So basically, that is the structure on E. coli that results in septic shock. So basically, gram-negative bacteria, E. coli, in this case, it's present on the outer membrane, and all outer membrane, sometimes outer membrane of gram-negative bacteria have endotoxin A on their lipopolysaccharides, and what happens is that they bind to LPS binding proteins, and then they get recognized by the macrophages by toll-like receptors, so in this case TLR4, and this can release tumor necrosis factor and interleukin-1, and can also release other cytokines and other inflammatory mediators. So over here, we're going to talk about norepinephrine and prazosin. So norepinephrine is the agonist, and the prazosin is the antagonist. So here we have a control. So basically, the agonist, what it does, it increases not only the potency, but also the efficacy here. And our prazosin, on the other hand, it is an antagonist. Now, there are two types of antagonists. There is competitive and there's non-competitive. So if it was competitive, then you would have a decrease in potency, but you would have the same efficacy. But if it is non-competitive antagonist, then there would be no change in, there would be change in efficacy, but there would not be a change in potency. So as you can see over here, there would be no change in potency, but the efficacy would definitely change in case it was a non-competitive antagonist. So yeah, so these are my sources. Thank you so much.